بسم الله الرحمن الرحيم وصلى الله وسلم وبارك على نبينا محمد وعلى آله وصحبه وسلم. Good morning, everybody, and highly welcome to this session. Dr. Dasugi Hassan, the director of the training center of International Hospital, and I am very glad to have here with us Dr. Mustafa Elnour, the known intervention radiologist in this country, and really I'm very happy to have him with us. Dr. Mustafa Elnour is an assistant professor of medicine, faculty of medicine, University of Khartoum, and he's the head of radiology department of International Hospital, and he's the director of cath lab, Soba University Hospital, and Dr. Mustafa is actively engaged in training of frontline service providers in this country and all over the world. He is a researcher as well with contribution in high impact journals. Dr. Mustafa, you are highly welcome and the floor is yours.
Okay, thank you so much, Dr. Dasugi, for this very nice introduction. Assalamu alaikum wa rahmatullah, ladies and gentlemen. I'm very happy that you're having me this morning. Today we're going to make touches on a very important topic, which is the chest radiograph. So why did we select the chest radiograph in particular? Why we didn't select any other topic? We selected this topic for one reason, because the chest radiograph is the most frequently requested imaging test in every radiology department worldwide. If you go everywhere inside Sudan, outside Sudan, you will find that the most frequently requested imaging test اللي هي صورة the chest radiograph. So chest radiograph has to be done properly. That's one. Secondly, it has to be interpreted properly as well, because uh, it gives very simple solutions to a variety of diseases. You can tackle with very complicated conditions and situations, and at the same time you might tackle with very easy things with these chest radiographs. طيب السلايدز بعدين من وين ماشي؟ ايوه اوكي. طيب this presentation this lecture was actually prepared by Professor Mahfouz. Professor Mahfouz is a well-known scholar of radiology in the region. He's an Egyptian. He died this year, 2025. Alayhi rahmatullah. He's one of our scholars. He's a 5-star teacher of radiology, and he's one of the guys, or one of the people who made science accessible to everyone, because his lectures are available everywhere. He's willing to teach anywhere. If you just invite him next week, he will respond. He taught so many radiologists and radiology registrars and clinicians. So this lecture was designed by him. So chest radiograph, this is a okay. So when you are asked about the proper chest radiograph, this is a proper chest radiograph. So the chest radiograph is, first of all, it's a PA. When you request chest radiograph or some people call it chest X-ray, but the proper name is chest radiograph. When you request chest radiograph for the technologist or radiographer in the radiology department, it's a PA. It's not an AP. It's not a lateral. It's not anything else. So this is a proper one. Is a PA. This is how it's being done. Okay. This is how it's being done. This is the image receiver. This is a chest tube or um, the X-ray machine. This is a radiographer, and this one is the patient. So the patient is facing the image receiver here, this one, and the X-ray tube is at his back, at the back of the patient. This is a light beam. We do our markers, or we demarcate the region by this light beam. That's to say the radiation should be here at this location only, because as we know, X radiations are ionizing radiations. They deposit those in the human body so that they are not quite safe. So you have, when you would like to do chest radiograph, you have to expose the area that you would like to examine. And this is a shield. And this is a shield. This shield protects mainly the gonads, because as we know, the most sensitive organs to the radiation are the rapidly developing cells. And the most sensitive one is the bone marrow, first of all. After the bone marrow come the gonads. And the least sensitive are those which are not multiplying at all, especially the brain. The brain is not sensitive to the radiation, but the meninges are very sensitive, because as we know, the neuronal cells are not multiplying cells. This is an AP. The difference between PA and AP is quite clear. The most important thing concerning the AP, you see the heart is bigger than the heart. Oh, that's okay. That's then الزر انتهت. Okay, تمام. طيب, this is a supine. This is a tube. This is a patient, and this is a table. The heart appears very large. Supine radiographs are usually done for those who are critically ill in the ICU and ER. This is a lateral view, and here we have the decubitus views. These are additional views. They are done when requested. For example, the decubitus views is a view that depicts the air fluid level very clearly. Right. So this is the optimal chest radiograph. How to assess the chest radiograph? Is it an optimal one or not? We have very few things that uh, we check. The first of all, chest radiograph should include the body from the lower neck to the upper abdomen and from the skin to the skin laterally. And the second thing is the exposure. It should not be so black like this and not so white, because this one we call it overexposed and that one we call it underexposed. The overexposed one, you can see the spine very clearly behind the heart. Uh, this is a properly exposed chest radiograph. So grateful. Me this way, mom.
Yes.
So this is a properly exposed chest radiograph, while this one is overexposed and this one is underexposed. This one. So we make this assessment before interpretation. We count the ribs. Anteriorly, we should have 6 anterior ribs, and posteriorly, we have around 9 to 10 ribs. For example, this is a case of emphysema. You see hyperinflated lungs. The lateral radiograph, we also check the retrosternal airspace and the retrocardiac airspace. All these are being checked when we do the lateral radiograph. Uh, we assess opacities. Very important thing concerning the radiograph is the centering. By centering, we mean the medial ends of clavicles should be equidistant from the spinous process. This is very important because if the patient is rotated, sometimes the patient is not centered like this. Patient has milder degree of rotation. This gives you a false impression of mediastinal widening, and we might report that this case or this patient has sharing whatever. Yes. Oh, okay. So it gives you a false impression of mediastinal widening. So this is a spinous process of thoracic spine vertebra, and this is a medial end of clavicle, and this is our medial end of clavicle. They should be equidistant anyway. This is a rotation. Here you see this medial end and that one, the medial end, this one, and the distance is not equidistant at all. So this is a rotated radiograph, and usually it gives you very false impressions and very false interpretations. Um, so this is a patient with obstructive airway disease. You see the intercostal space is very widened. These are the fissures. We assess all these. So I would like to move quickly over this because the most important thing is the interpretation rather than this meticulous assessment. So this is a major fissure, which we call it the oblique one, and this one is a minor fissure. Um, the minor fissure, of course, is on the right side. We call it the transverse fissure. And here, this is a diaphragm. It's elevated, and you can see bowel loops pushing it. Okay. So the most important things that we are going to touch are the signs. And I think this is the most important part of the lecture. So we have so many signs. When you read a chest radiograph, you have words like consolidation, cavitation, um, nodules, ground glass opacities, silhouetting sign. So all these things, this is the language of radiology. All these things or all these signs should be clear to the one who requested the exam and to the one who is treating the patient. So by silhouetting sign, we mean this is the heart. You can see the heart border very clearly. Here you cannot see the heart border. So this is a silhouetting sign. Silhouetting means inability to see the things very clearly. So this is a consolidation or it's an opacity because when we talk about chest radiograph, we prefer to use words like opacity. It's better than consolidation. It's an opacity um, in the middle lobe. When you have silhouetting of the right cardiac border, this is a middle lobe disease. When you have silhouetting of the left cardiac border, this is a lingula. So, and here we have an opacity with airspace consolidation. So, terminologies. We have masses and we have nodules. What's the difference between mass and nodule? So, what's the difference between mass and nodule? As you can see, the mass is a big thing and the nodule is a small thing. The demarcation point between mass and nodule is, is the size. The nodule is anything less than 3 centimeters, while the mass is anything that's more than an opacity that measures more than 3 centimeters. So everything that's more than 3 cm, this is a mass, and every opacity which measures less than 3 cm is a nodule. Cavity is a cavity, as we all know. Uh, you can have a cavity like this, and you can have an evolving cavity. This is a cavity containing gas and fluid, and this is an air fluid level. Again, here we have a patch. Mm, this patch, this word was very famous during the era of COVID-19 because COVID-19 gives you patch ground glass opacities. So patch is patch طبعا بالعربي معناها رقعة مش كده؟ ف this is a patch. بينما batch معناها شنو؟ دفعة مش كده؟ يعني مضادي is my batch معناها دفعتي في الجامعة، بينما patch معناها رقعة. So ما قلت لك صورني. Okay. So how to interpret? As we said, first of all, should be of optimum quality, and we start with the patient data because you have to give the proper interpretation for the proper patient. If the image is not or doesn't belong to the patient, definitely you make a big disaster. So the patient data are very important. The previous films might be needed. So the pathology, we have focal and we have diffuse. Again, focal lesions could be nodules, masses, patches, cavities. We define every one of them. For example, this is a mass because it's more than 3 cm. Nodule is less. Here we have a cavity. So when we talk about the location of the abnormality, we have the zonal, zonal anatomy. The zonal anatomy, we divide the lungs into 3 zones: upper zone, middle zone, and lower zone. The upper zone is the first intercostal spaces, the first one and the second one. The second, the third and fourth, the anterior, I mean, طبعا, the middle zone, and here the fifth and sixth are the lower zone. So here we have an upper zone cavity containing containing air fluid level, gas and fluid. We have, as we all know, we have predilection of disease to certain locations in the lung. For example, the lung apices and the apical segments of the lower lobe, these are very much preferred by tuberculosis in Sudan in particular and in countries like our country. The lingula is a site for malignancy. So when we have an opacity with curing the lingula, we have to think of the bronchogenic carcinomas and the wide spectrum of that disease. The middle lobe is a site, and the middle lobe and the lower lobes are sites for pneumonias, foreign bodies, and others. But what these are what you see when you correlate the things with the clinical history. You make the diagnosis of of the disease. As we said, nodules less than 3, 6 common. These are multiple nodules. We have this metastasis concerning the multiple nodules. We have tuberculomas, hamartomas. These are usually solitary ones. AVM solitary, iditis solitary, while the metastatic deposits are usually multiple. Uh, so concerning the nodules, these are the important things that we look for, no, not we look at. We look for these things, and the difference between looking for and looking at is very clear. You look for something, that means you are exerting an effort. You are doing an effort to look for something. But when you look at something, you are doing things passively. I just watching the thing. But when you look, when you have a look at the chest radiograph, you look for things. You don't look at the things. So here we have seen this. It's well defined, no calcification, density. It's an opaque vascular pedicle. It's there. So we have to think about, look at this, for example. We have a vascular pedicle. Here we have this vascular pedicle connecting the lesion to the hilum of the lung. So this is an AVM. Here we have water density on backgrounds of very clear lungs. So most likely this is a hydatid disease. And when they did the surgery, it was a hydatid disease. The difference between abscess and hydatid is very clear as well. The abscess has a thick wall. This is CT, of course, alone. But while the hydatid cyst had a very thin wall, and here we have a gas bubble, and we have enhancement of the wall. So the difference is very clear. This is a hydatid cyst after surgery. Abscess, antibiotic therapy or percutaneous drainage can do the job. Um, Encysted pleural effusion is a very important entity because it's a great mimicker of lesions. So you have this patient with an opacity at the middle zone. It looks like anything, but it's overlying the fissure. When we did the lateral radiograph, it's just overlying the 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 minor fissure. So this is encysted pleural effusion rather than mass. Um, Sometimes you go to CT because it has the ability to give more details about lesions. So this is a lesion with calcification inside and calcification inside here. So we have the tuberculosis and the hamartomas, they come into play. Uh, Again, when we talk about CT, as we said, we talk about the margin, the calcification, the vascular pedicle. Look at this. We have this opacity at the lower zone. It's speculated. It's not of clear outlines. When we did the CT, it has these speculations. So this is definitely a sinister finding. This is not something benign. And when the biopsy was done, it was a carcinoma. Again, here we have another bronchogenic carcinoma. You have these speculations. And here we have the vascular pedicle. So this is not a carcinoma. This is uh, an AVM. AVMs are so many. So this is pulmonary angiogram. We used to do this kind of test before the era of CT angiogram. Nowadays, no one is doing this to diagnose the AVM. We just do CT with contrast. We have an opacity here. We did the angiogram and it was an AVM. So let's move. So nodules, as we said, uh, a mass is more than three. We have common masses, the carcinomas. طبعا hydatid depends on where the patient is. Then in an endemic area, you think about hydatid. Or metastatic deposits. ممكن يكون عندنا solitary metastatic deposits, especially from osteogenic sarcomas. So this is a 50-year-old male with an opacity on the right side involving the middle and lower zones with overlap. When CT was done, it's a mass with retrosternal lymphadenopathy. This is CT with contrast, and this one is a plain CT. So that was a malignancy. Here we have a 29-year-old male. We have an opacity here at the left upper zone, and it's well defined. We have to remember the left side is the side of great vessels, especially the aortic arch, the descending aorta, and even the neck vessels. So when you have, and the upper limbs, of course. So when you have an opacity here, usually put at the back of your mind, it could be a vascular. A vascular thing could be aneurysm or anything like that. But this was a tumor. It's just close to the vessel. This one can be biopsied, of course. Again, we have this very big tumor. It's a solitary one. It's a mass. This is very famous kind of metastasis from osteogenic sarcoma. Um, these are well-defined opacities. Could be cystic or solid because the chest radiograph usually does not discriminate between these. So the differential between metastasis and hydatid, but anything is which is well defined like this, usually you go to benign things. So when we did the CT scan, just fluid containing cysts, very thin walled cysts, and these were hydatid cysts. So now we have patches. Patches usually pneumonias or infarction. So this is a patch with air bronchogram. Infarction, sorry, not infection. This is aerospace consolidation because we have the air bronchograms. Here we have the air bronchograms. This is most likely pneumonia. But this one, this one is a very famous finding concerning radiology. Um, we have airspace filling with air bronchograms as well, and it has a very unique shape. We just call this shape the bat wing because it just looks like the wings of the bat, الهول. So when we deal with bat wing infiltrates, it's usually either cardiac or non-cardiac. If it's cardiac, that's pulmonary edema, cardiogenic one. If it's non-cardiac, the differential is very wide and includes so many conditions. So alveolar edema, we have, uh, yes, that's ممكن تكون blood، ممكن تكون tumor cells، alveolar cell carcinoma، ممكن تكون alveolar peritonitis, this one. All these can give the same picture, but that will depend on the clinical presentation and the other findings, especially the laboratory. This is how we see pneumonia. Nothing is clear here on this chest radiograph, but when we did the CT, there is a lower zone opacity or lower zone consolidation. After treatment, muscle clearance. There is a very important point concerning these follow-up radiographs and follow-up CT scans. Usually concerning pneumonias, we don't expect to have uh, immediate radiological improvement because the patient receives the treatment, gets well, goes back to home. When he's brought back to the hospital and we do the follow-up radiograph, you might find it, or the follow-up CT scan, you might find things like this, and the patient is very well. So in this situation, we just tell the patient there is usually a lag of the radiological improvement behind the clinical improvement. The patient clinically gets very well and radiologically is still having findings or opacity. And very importantly, as we have been taught by our great teachers who taught us in the Faculty of Medicine, usually treat the patient and don't treat the image. So this is pneumonia again. Uh, this is a case of pneumonia versus infarction. The pneumonia has air bronchograms, while the infarction, we don't have this. Uh, okay. Uh, cases with infection, طبعا the most important cause for infection is the PEs. And PE, by the way, is very common in 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 patients with those who have predisposing factors, and even um, in patients in the ICU, those who are bedridden. You have to think. For example, yesterday there was a patient referred for CT abdomen, a patient of intestinal obstruction admitted here in Abdaman in the ICU. When they did the CT, he had massive PEs and massive PEs, طبعا pulmonary emboli, and he had also massive thrombosis of the superior mesenteric vein. So the plan of management changed completely. He was referred to the imaging department as a case of intestinal obstruction, and the diagnosis was that of pulmonary emboli, venous emboli concerning the mesenteric veins. Fortunately enough, he didn't have bowel ischemia. So these are the emboli. They are associated with the infarcts. With pulmonary infarcts. آه نرجع تاني، لأن في الصور دي نحن كل مرة وبنعرض لكم the same findings. For example, عشان الناس تكرار مرات مفيد. So here we have a cavity. This cavity with an air fluid level. While this cavity has a soft tissue opacity inside. The differential usually includes things like the fungal balls, especially this one is well demarcated, and it could be sinister, could be a tumor بالمناسبة. عشان كده further workup. So when we do the CT, we assess the inner margin and the thickness of the margin, and we look at the inner margin of the lesion itself. For example, here we have a thick wall, but it's very smooth. Usually, this is the wall of tuberculous cavities, and especially the location. This is a posterior segment and apical segment of the lower lobe. This is the site predilection for. But when you have something like this is a specimen طبعا في الباثولوجي histo profile dot, and this is uh, the image. You see, we have irregularities, and here we have the irregularities. So this was a cavitating bronchogenic carcinoma. Here we have very smooth cavity, so I mean wall, but we have air fluid levels. This is an abscess, and this is a chronic cavity, means it's tuberculosis. Okay, طيب. So as I said, you have to look at the site of the lesion. It's very important because diseases have predilection to certain locations. Tuberculosis loves the upper lobes. Tumors can stay anywhere. Lower lobes are sites for foreign bodies. This is a very important radiograph. This case is a smoker, is a heavy smoker. Usually, we tell people don't smoke because smoking is a very bad habit. It gives you diseases. They don't believe in that, and they continue smoking like, and they end up with these conditions. This is that one was طيب الزوجة ده نرجع للصورة الأولى دي، الصورة اللي قبل دي، السلايد اللي قبلها أيوة this one. So these are air-filled cavities located at the peripheries of the lungs, and we call this the paraseptal emphysema. It's typical for smokers, typical. And this is irreversible damage for the lungs. The only treatment for this one who was smoking all the time is lung transplant. He damaged his own lungs, and he will look for lungs that are very precious and will never find them. So this is, again, we have an air fluid level. at the lower zone related to the diaphragm, sorry, at the middle zone. Again, we look at the margin, we look for thickening of the margin, air fluid levels, we look for all these things. Uh, Again, we have a cavity. This is chest radiograph. You have this cavity and an opacity inside the cavity. This is the gas and this is the opacity. So this is a fungal bulb. But it could be a necrotic tumor. Yani not all things are just fungal bulbs. CT might be needed just to differentiate between the things. So look at this. Again, we have a cavity, we have a ball inside. So that was a fungal ball, but the differential is very wide. We look at the wall, we look at the inner opacity. The wall is well defined. We don't have modularities, and even the inner opacity looks well defined. So this could be diagnosed as fungal ball. So this is the last slide, and this is how we look at the things. Cavity lesion, cavitary lesions, look at the contents, air fluid level, air only, look at the wall thickness, and at the end, you can diagnose cavitating neoplasm and nematocysts and even emphysemas. So chest radiographs are very simple. Everywhere you can see them, even if you go to the outstations, you find an X-ray machine, a radiographer doing these radiographs. Interpretation is not that difficult, but you have to have the core of knowledge to make very good interpretations. So thank you for your attendance and your patience. And I hope the lecture was useful to you. And now I'm ready for questions if you'd like to ask.
Thank you very much, Dr. Mustafa Elnour, for his excellent and dedicated presentation as usual. And now the floor is open for discussion. If you have a question, please. Our colleague who are joining us through Zoom, now you are unmuted. If you want to ask Dr. Mustafa or if you have a comment, you just unmute yourself and tell your
السلام
comment.
عليكم. السلام عليكم.
عليكم السلام.
Thank you والله يا بص يديك العافية. المحاضرة very informative و very useful صراحة. الله يديك العافية إن شاء الله يا رب العالمين. بس عندي سؤال في حكاية النيماتوسيل، لو بس نعرف إنه كيف نفرق بينه وبين الكافيتيز الثانية، وفي الكلينيكال براكتس الامبورتنس حقتها شنو مثلا النيماتوسيل بالذات.
Okay, شكرا جزيلا أفاق على Thank you so much, Afaq. It's a very nice question. It's a great one. طبعا, as I said before, doing any or before making any interpretation for chest radiograph, you go back to the history, and the history, of course, guides us to the diagnosis. And you are the ones providing us with the history, so it must be quite different from that history of malignancy or that history of hydatid cyst. This one and the nematocele, طبعاً, the cause is quite different. It could be due to infection, could be due to trauma, مشكلة. There are so many. But concerning the imaging, nematoceles are usually very thin-walled, containing gas, of course. As we can see here in our diagram, the nematocele and it's located here at this site and not that one. So it's containing gas only, it has very thin wall, and the background of lung is very clear. The hydatid has the same characteristics, but the hydatid is an opacity. It's because hydatid cyst is a cyst and it's containing fluid inside. And As I said, the image can tell you, but the most important thing, the clinical history also tells us the solution.
Thank you very much. It's very clear.
Thank you, Wafa, for your question. Now we have our great teacher, Professor Ahmed Abdullah Doctor. If we can link things together concerning the pathology, the clinical presentation, and the radiology. Yes. We know that there is a pneumonia and there is a pneumonitis. In pneumonia, we have consolidation. In pneumonitis, we don't have consolidation. But can we link this together? First, Professor Dr. can tell us the difference between pneumonia and pneumonitis, and Dr. Mustafa can tell the differentiation.
Okay. اتفضل.
شكرا جزيلا. Regarding the question, the differences are double fold. Pneumonia is the term used to describe lower respiratory tract infection by British people. In British domain, there is nothing called pneumonitis. Pneumonitis is almost, this is a term used by Americans. This is one. The other difference is classical pneumonia, there is consolidation. Right? When there is no consolidation, usually the pathology is affecting the interstitium. So the very thin connective tissue layer that is found just outside the alveoli. Usually the term used commonly is either interstitial pneumonia. This is what they call British folk. Interstitial pneumonia, or sometimes an atypical pneumonia. So these are the differences. If we are following the bridge way of thinking and naming things, we usually talk about pneumonia, which means pneumonia with consolidation, with accumulation of fluid intra-alveolar. Or we talk about interstitial pneumonia, where the pathology is in the interstitium and the alveoli are filled with fluid. And above, I would like to take this opportunity and comment on السبريشن. طبعا نحن في التعليم العالي بنتكلم عن مع باس إلى excellent. طبعا في حاجة above the excellent. Above the excellent is outstanding. So it is definitely an outstanding election. It's not just excellent. So it's an outstanding. And برضو عشان أشكل نفسي معه بقول this is usual for diagnosticians. They are always outstanding. طبعا the main difference is we see things and others hear about them. This is a very big difference. وفي المحاكم ونحن بندرس forensic medicine, legal part of it, there is a very big difference between eyewitness and hearsay. Right? What we do is we are eyewitness of medicine. طبعا interventional cardiologists are also eyewitness.
Thank you very much for this valuable comments from our great teacher and the father in the faculty of medicine, Professor Abdullah Doctor. And as he said, usually investigations are routine blood tests or other tests, and you go through imaging, and then you go through procedures. Usually clinicians better to follow this routine test, then you go for imaging because it is non-invasive and cheap and available, and it is easily interpreted like X-rays, like abdominal ultrasound, and these things. And then you go for procedures like bone marrow, like aspiration, like these things. Dr. Mustafa Do you think chest X-ray, although you are not يعني practicing clinical medicine, chest X-ray is a part of routine examination. يعني do you believe with this talk إنه if you didn't do chest X-ray for a patient who is critically ill presented in the ER, you didn't complete the examination? Do you believe on this?
Okay, thank you, Dr. for this very important question. Um, as we all know, investigations should be tailored to answer certain questions. Critically ill patients are just as the name implies, they are ill. They might have affection at the chest, concerning the brain, concerning. So you never know. Things might go into directions because, as I said, I have that patient, which I saw yesterday, a patient with intestinal obstruction, and they were preparing him for surgery, and they did for him the CT scan. It was just CT abdomen, but as we know, in CT abdomen, we scan the lower chest. So we ended up with massive PEs and massive superior mesenteric vein thrombosis. So, but again, the chest radiograph concerning the supine patient, because the ICU patient is a supine patient, we do it using the portable machine. Even this has interpretation which is somewhat incomplete and difficult. Nowadays, we are talking about the ultrasound for the ICU and what we call it the fast scan. We train the residents in the ICU and the emergency residents on that thing, and they do it very efficiently. And it gives us diagnosis for many conditions. For example, if I would like to diagnose pleural effusion, ultrasound is better than X-ray. If I'd like to diagnose even basal consolidations and peripheral consolidations, ultrasound is very much preferred. And even for the pneumothorax, we can do ultrasound for the pneumothorax. We do our M mode. We see the pattern of M mode. We have the seashore, and we have other things. We can diagnose pneumothorax on that. So the things, as we know, since usually are not straight like that. Okay.
Thank you very much, Dr. Mustafa. Any questions, comments on the floor from our colleague who are joining us through Zoom? Dr. Mustafa, you talk about chest ultrasound, which is under requested nowadays. I
Yes.
mean, people usually don't request chest ultrasound, which is one of available tests. And as we know that the main limitation of ultrasound of the chest is bone and hair,
Yes.
and the window as well.
Yes.
How can you solve these problems?
Yeah.
And in what conditions we can just request chest ultrasound?
Okay. طيب thank you دكتور. طبعا chest ultrasound is most frequently being done in the ER and the ICU. But concerning the mobile patients in the clinics, usually we do the chest ultrasound as a complementary scan. Usually patients have already done their chest radiographs, and there is a finding. For example, in cystic diffusion, we just do the chest ultrasound to tell whether this is empyema or anything, and at the end of the day, we aspire it. So it's complementary rather than the first test. The first test still for ambulatory for moving patients is the chest radiograph. But the ultrasound, we do it just to complete the picture and to answer certain questions. That's it.
The window usually goes
Okay.
subcostal or
Okay. Yeah, the window, طبعا it's very important. As Dr. said, gas usually hinders ultrasound. When the ultrasound waves go through the gas, they can just come back. They don't penetrate the gas. And that's why you don't have any picture behind the gas. So when we do the chest ultrasound, we usually have selection criteria for our patients. We prefer to do it on peripheral lesions rather than the central ones. Because the patient has a central lesion and he puts the probe, definitely I'm going to see nothing. This is one. The second thing, we concentrate on fluid-containing pathologies and consolidations rather than cavities and hematocytes and those things. In such a condition, ultrasound can give us, and the most important thing is the location, because if we have a central location and structure totally surrounded by gas, we don't see anything. Okay.
Okay, thank you, Mustafa. Any questions? If we have no questions, I have to conclude this session. But before conclusion, Dr. Mustafa, if we can combine and take home message for the most important findings clinically and radiologically.
One small comment.
Okay. تفضل بروفيسور تفضل.
طبعا معلش I would just like to emphasize على نقطة مهمة ذكرها الدكتور مصطفى. Diagnosis cannot be done in vacuum. يعني diagnosis is made up by just compiling clinical data, including the history, clinical findings, and other radiological or laboratory findings. وبالتالي providing adequate, informative clinical data is an integral part of any diagnosis. We cannot diagnose in vacuum. People usually think, they need to challenge the diagnosticians by not providing them with adequate data. This is wrong. Diagnosticians are clinicians, basically. They just take the data you provide, the history, the clinical data you provide, and then they add them to what they find to suggest or to make a diagnosis. If we are providing adequate clinical data is an integral part of diagnosis. You cannot diagnose any disease on earth without providing clinical data. The other thing is this concept. Unfortunately, this is you don't, if you provide them with data, they will just, they will cook the findings accordingly. This is wrong. This practice has to stop. Without adequate clinical data, no diagnosis can be made.
Yeah. Thank you so much, Professor Ali Abdul. That's the thing. Good data, good diagnosis, يا جماعة. Thank you so much.
Okay, thank you very much, Professor Wallahi. And I have to say that when you provide the data for someone to help you doing an investigation, you have good doctors are those who get good salary. Sometimes people, they just write a paper and written on it echo or ultrasound without providing any data concerning the patient. And some of them, they fill the whole. And the good is to give good salary. Good doctors are those who give good salary, give the most important clinical information to the person to help you to reach the diagnosis. Another, our teacher, Professor Ahmed, says that more than 90% of the diagnosis may be catched up by clinical assessment of the patient, history and examination. And probably the investigation will add a very little part in the workup of observation. So history, examination, and interpretation of this data by forming clinical diagnosis will help a lot in the diagnosis of the patient. Thank you very much, Dr. Mustafa Elnour, And thank you very much for the audience, and have to conclude the session. See you next morning.